Hi, this is Joe Mullings with The Other Side. Today, joining us is Tim O'Malley. Tim is President and Chief Growth Officer at EarlySense, and Tim is joining us from Boston today. Tim, welcome aboard.
Thank you. Good to be here.
I hope all is well up there. What's happening in Boston right now, lately?
So this morning I read that there's roughly 15,000 cases of COVID-19. There's been a pretty early response from the people here as far as setting up sites for overflow or surge patients into the facilities. So I think for the most part, from a caregiver perspective, I think they're fighting the battle and I think they're doing okay, but I think it's getting a little more intense each day now.
Yeah, yeah. Hopefully everybody close to you and yourself are staying safe up there. And now EarlySense, I was really interested when I heard about EarlySense a few months ago. I was in Israel at the time, and we were on with Sheba yesterday in the ARC program and with Michael from TriVentures.
TriVentures.
Yep, TriVentures. And EarlySense continues to come up, and I had a chance to interact with it at TriVentures when I was in Herzliya. Share with us a little bit about EarlySense and how that continuous monitoring is an emerging category in the medtech industry, and where is it fitting in COVID today?
Yeah, so continuous monitoring really started. EarlySense was one of the early pioneers in entering into this new patient monitoring modality. If you look at a hospital typically without looking at the COVID-19 situation, most hospitals, 60 to 70% of patients are not continuous monitored. The patients in an ICU, the patients in an OR, patients in a recovery area from the OR or PACU will be monitored pretty much one-on-one. But once they leave those environments, they're monitored more on a spot level, meaning that the nurse will come around or a nurse's aide will come around and monitor a patient by doing vital checks every 4 hours. And, over the years, that's created problems where you have, a orthopedic floor, for example. You may have a relatively healthy person that is being given pain treatment for maybe an orthopedic procedure. And if they're not monitored on a regular basis, these patients could get into trouble due to anything, due to side effects from the pain meds, due to respiratory drive depression, which may happen because of pain meds, et cetera. And so we really started in the U.S. about 8 years ago, entering into the U.S. hospital market and tried to get into this modality where we wanted to raise the level of awareness around continuous monitoring, the need for it, because there's a whole lot of patients out there that really should be monitored on a continuous basis, both in the hospital as well as outside the hospital.
Is there a series or a set of biometrics that is custom to what we are tracking, or is EarlySense just go through a family of biometrics that you deem valuable? How is that established?
So our technology is very unique in that it's a non-contact way to monitor. We put a sensor that's about the size of a legal pad of paper underneath the mattress, and we can capture wave shapes that the body produces in the form of motion. And we then interpolate those wave shapes through our algorithms. And we have over 15 million hours of patient data in our algorithms. We've monitored well over 1 million patients to date. And, through this, we can capture updates twice a second to the respiratory cycle and the cardiac cycle without ever touching the patient. And so this becomes a very unique advantage for this technology, especially when you're talking about patients that may be isolation-based patients.
Yeah. And you're running into that today. Are you being used in a COVID environment today?
We are. We actually, in Sheba Medical Center over in Tel Aviv, they set up EarlySense really for two reasons. It becomes a benefit to the caregiver and to the patient because from a caregiver's perspective, you can slide the sensor under the mattress and it doesn't touch the patient, and you can remotely monitor that patient from outside the room. And so with that, you save the caregivers from having to get, their protective gear on every time they go in to see the patient. They can now look at things in a very rapidly updated manner from outside the room, and they can also be assured that the sensor is not touching a patient. And so, from an infection control perspective, it's an advantage. And from a patient perspective, when you have that rapid of an update, any change that may be developing and occurring, and what we're hearing clinically about these COVID patients is that the changes happen quickly, especially to their respiratory system. And so, having something that updates twice a second gives a large volume of data. And so, with our algorithms, we can do some predictive capabilities as well around what that data may represent.
And so that's where I was going to go next, is this brings in the capabilities of a predictive analytics scenario. Is that right?
It does. And not just with COVID patients. I mean, we also, because we're capturing wave shapes from the body, we look at gross body motion and movement. And, we are used in about 200 post-acute care facilities across the United States. A big reason for that is because we will help them predict the patient trying to get out of bed. And it's a very effective bed exit mechanism for alerting to the caregivers or the staff that a patient may be attempting to get out of bed versus they've already gotten out of bed. Most bed exit systems are based off pressure. And so, if you think about that, you're on the pressure mat or you're off the pressure mat. And if you're off the mat, then your chances are that you're already up. And with a high fall risk patient, that may be too late. It may be that that patient's already at risk. And so with our system, it's used a lot to give early warning to things like a bed exit to prevent a fall, early warning clearly to any kind of deterioration from a patient perspective on respiratory or cardiac performance from that patient. And so with that, it certainly has a predictive element to it.
Given that you're on the ground at Sheba in Tel Aviv, are there any learnings or any insights that you had not expected with the EarlySense platform that you're learning real time over the last month or so since this has been engaged in patient care?
Yeah, like any algorithm-based system, I mean, we have to constantly collect data to improve the system and improve the different applications. And one thing we have learned is that many facilities, and we also have started to install our system in facilities here in the U.S. now as well for COVID patients in the New York area as well as within the VA system. And what we've learned out of Sheba early on is that many of these patients will end up being ventilated while they're on their stomach. And apparently there's a difficult time, and it's obvious if you have, electrodes and leads on a patient and you're trying to monitor them with a traditional manner, you're going to have interference from them lying on their stomach when you have electrodes pressed between the patient and the mattress. And our system does effectively monitor even when the patient is on their stomach, because again, we're looking for motion and taking and analyzing that motion and deriving that into a cardiac and respiratory cycle.
The digital window that EarlySense provides, and that's something I'm lifting from our friend Joe DeVivo over at InTouch, but that digital window that EarlySense provides, how valuable has that been, at least with the data you have to date? Again, I'm going to stay in this COVID situation right now, and what lessons are we going to learn on the other side of this that, if not but for, because of the volume of information we're getting?
Yeah, I think, it's been well known that patients deteriorate and they give warnings to that deterioration hours typically before they actually desaturate or decompensate. And when you're looking at respiratory rate, it is the earliest indicator for a change that may be happening physiologically with the patient. And I think that this is going to put an explanation point around that, because obviously these are respiratory distressed and compromised people. And, having earlier indication of a change in respiratory rate should give the caregivers an indication that these patients are changing and there may be other things that need to be looked at.
And so with a obviously clearly overworked, overburdened, and stressed out system as well, we're not able to, even in a regular day, check in on a patient, let alone in the hallway, in an ICU, or even a standard room, given the overload right now in every single healthcare center. That's got to be valuable. So tell me how that system works. Does it reside on an iPhone on the caregiver? Does it sit at a nurse's station? How do I get that alert?
So, the great thing about technology and what's happened in the past, 15 to 20 years is have smartphones and tablets that are, as powerful as computers today. And so, whether it's a laptop or a desktop. And so the ability to process this data in a variety of ways is very much there. And we've done this. We've done sensor interface into, for example, a smartphone. And I think as we kind of emerge out of this COVID crisis and people look back and say, what did we learn from this from a monitoring perspective? I think what's going to come out of it is that patients really need to be monitored in almost every location. And whether that location is an OR or an ICU, a general med surg environment, a post-acute facility, a lot of these patients, unfortunately, these COVID patients are going to end up in these post-acute facilities for treatment, for continued treatment. And clearly, if they were ventilated in the ICU, they're probably going to end up in a post-acute care facility for a period of time to be, rehabilitated and treated further. And then they'll end up in a home, hopefully in their own home, where, there should be monitoring there as well. And I think that the fact that you have a non-contact sensor, and there's other ways to monitor these people. There's wearables that are coming that provide similar data and capabilities. But I think having that continuous element is going to be a critical factor going forward. And I think whether it's a wearable or a non-contact sensor from EarlySense, or in some cases, contact sensors on the body, which are a little bit more traditional, I think that this is going to be a big lift for continuous monitoring, which it should be.
Yeah, you bring up a point here that I don't think a lot of viewers understand, that just getting somebody on a ventilator certainly is critical to the success of their outcome. But the post-therapeutic impact on that patient who's been on a ventilator, would you take us down that path to the best of your ability?
Sure. So, if a patient is on a ventilator, we hear, from the different places we've heard different projections of mortality for these patients, and it can be pretty high, obviously. The goal of the caregiver is to reduce mortality as much as they possibly can. If they end up putting a patient on a ventilator, it's because the patient doesn't have the ability to ventilate themselves, and they need to have the ventilator to assist and help the body heal during that time of rest, if you will, of the pulmonary system. Many times these patients may end up with a tracheostomy that is going to be in the patient for a period of time, hopefully during a short period of time, so that they can wean them off of the tracheostomy in, for example, a rehab facility that specializes in pulmonary rehab patients. And hopefully these are the patients that end up going into these post-acute facilities can be rehabbed and extubated from the tracheostomy down the road from their time in the ICU. Unfortunately, what I've read and heard from physicians that I've known for years, and I have a background in respiratory care because I spent a bunch of years at Siemens and ran their ventilator business for a number of years. And what I'm hearing is these patients tend to stay on the ventilator for quite a long time.
Yeah, and you talked about the mortality rate. I've heard up to a 50 to 60% mortality rate on a vent for the most part.
Yeah, I just read an article today from one of the world-renowned pulmonologists, Dr. Gatnoni out of Italy, and he's been ventilating patients successfully for years. And yeah, I think the mortality rate is in that 50+% range. And what I gathered from this article I read this morning, even people like him who have now taken care of these COVID-19 patients learned new things about this, because it's a brand new sickness that we haven't seen before. Yeah. And ARDS can develop in a lot of different ways. With these patients, from what I read this morning, you have to treat them differently to get better outcomes.
Yeah. Yeah, and the data, the amount of data now that we're able to add some intelligence to, thanks to that connectivity, whether it's an early sense or the triangulation of other data up to the cloud. I think the ability to learn at scale over the next 5, 6, 7 months as we continue to work through this, depending on where the horizon is, I'm hoping that there are more connected devices like EarlySense and others than not, and we're doing something with that.
Yeah, I think, to your point earlier, Joe, predictive analytics, I think, is the future. I mean, having spent a long time at a big company like Siemens, we were kind of, you know, um, encouraged to think out of the box on the future and what we could do as a company to bring more innovation to our different clinical modalities. And one of the things that I remember working on was, we didn't call it predictive analytics, but it was, kind of building databases around the history of patients. And so if you think about a patient that you're monitoring in a telemetry situation, in a cardiac ward, you're collecting just thousands and thousands of wave shapes and, different arrhythmia runs that occur. And what we kind of talked about, and this was 25 years ago, we talked about, if wouldn't it be great if we could take all this data that is being looked at and collected by the system and build predictors for future patients that you can predict based on this rich history of information. You can build predictors, and we are doing that at EarlySense. We've actually built predictors around early identification of things like sepsis. As I mentioned, bed exit, although it sounds like it's a fairly simple thing to do, it's really not. And I think the future is great for the medical consumer. It's great for the healthcare systems. I think that it's great for people that want to be able to monitor and manage their own health, because you can have sensors everywhere. And, not that you want to overload people with all this data that they may not understand, but when you think about predictive analytics and you think about having the best and the brightest people looking at some of that and managing patients around what they're seeing, if you have good quality signals, which you get from sensors today, and you have good processing capability, and you can build into a database with other information and parameters, it could do a lot to prevent things from going bad.
We hear about how doctors, even before, or even caregivers, even before the current scenario we're in, were really overworked. And I've been at this for 3 decades and have been on the leading edge of using data and predictive analytics and insights, let's call it surgical or healthcare insights. But when you have a high fidelity signal and you have data and you have predictive analytics, and then you want to manage patients, does healthcare look forward? Healthcare looking forward, it's got to look different than it does today in regards to workflow. Does somebody or something get put in between that sensor and finally the doctor who's already overworked, whether it's filling out paperwork or billing or transcribing notes? What does it look like from your perspective?
So I'm a big believer in aggregating the data. And so as you think about a physician or a nursing staff, they are overworked. I mean, they are in some cases in a terrible situation trying to manage people that are pretty sick. And I'll tell you, having also been in this industry for 3 decades, a little bit more, but around 3 decades, it's changed. It's changed a lot. The nurse to staff, the patient ratios have changed. The complexity of patients has changed. Where these patients are cared for has changed. And I think that's accelerating now. And I think that when you think about it, to give somebody in the OR a vast amount of information, you have a one-to-one relationship with a patient in the OR. You have an anesthesiologist that's managing all that data real time. They're trained extensively on how to do that. Then you move that patient to a recovery or a post-anesthesia care area. You may have one nurse for 2 patients, one nurse for 3 patients. Those nurses are also trained to do a lot of one-on-one care for patients and assimilate that data. But then you move to the general floors. Now you have one nurse for 4 patients or 6 patients or 8 patients. and they may not have the training that the OR nurse does or an ICU nurse does in how to really interpret this data. And I think there's ways that we can put this into dashboards and risk stratify the information for that caregiver, so that if that nurse is caring for, let's say it's 6 or 8 patients, she'll know which 1 or 2 are at higher risk than the rest.
Mm-hmm.
And I think that's what's going to be critical going
forward. Yeah, agreed. So you are president and chief growth officer at EarlySense, and obviously EarlySense is currently sitting on the forefront of where healthcare is going. You probably forward facing are in pretty solid shape as we move very rapidly into a sort of data enabled healthcare telemetry driven business, but there are others who are not. And whether it's elective surgery or post-market clinical trials put on hold, or even clinical trials put on hold, what's your guidance to those CEOs? I mean, you're a veteran here. What's your guidance over the next 3 to 6 months to those CEOs, or, the young Tim O'Malley back in the day? What would that be?
So, I mentioned earlier, we have a partnership with Hillrom, the largest bed company, where we put a sensor in every Hillrom Centrella bed today, so that a bed now becomes a monitoring station as well, which is fantastic. I think it's probably overdue, and I'm glad to see that we're doing this with Hillrom. When this whole COVID crisis hit and kind of froze up the country, we have a small direct sales force of about 12 people that were calling on post-acute nursing homes, skilled nursing, rehab centers every day. And all of a sudden, they couldn't get in. They just couldn't go see customers. They couldn't get into their market. And so what we did very quickly is we said, look, your world, our world, the customer's world has changed. And so we have to change. And I think that having the adaptability to say, where do we go now? And what we did is we basically pulled as much information as we could about where at the federal level the information was going, where at the state level the information was going around treatment, around facilities, around funding, and where it was going at the local level. And we remobilized our sales team. We have a few inside salespeople and then 12 outside salespeople. And we said, look, you can't get into post-acute, so you need to go to these organizations. You need to call, you need to email, you need to find out, and basically rebuilt a script for them. And thankfully, it's been successful. So what we did is we learned from that there was a whole bunch of information through these people that pointed us in different directions. And frankly, the last month or so, our focus shifted from post-acute back to hospitals as a result of it, because the hospitals are the ones that are fighting the war right now. And I've been a strong believer that people in our industry buy things for one of 2 reasons. They're either in trouble or they're in a growth mode. And no one's in growth right now. They're all in trouble. Mm-hmm. So you have to figure out what you can do with your solutions and how it will help them get out of trouble. And you have to train and script your people appropriately that they can deliver on that message. Yeah. And that's what we've done. And I think that adaptability and flexibility and speed to those changes is key.
Yeah, great advice, great insight. I think that is great insight for every industry, not just the med tech industry, given where we're into now. Well, Tim, I do appreciate your time and insight. The EarlySense continuous monitoring, I think, is going to continue to be and needs to be a large uptake in the marketplace. So I appreciate the time on that today. And stay safe up there in Boston. And if there's anything at all, can we reach back out to you if need be?
Oh, sure. Absolutely. Be fine.
Right. I appreciate it.
You too. Stay safe, Joe.
I will. This has been Joe Mullings with The Other Side.